Federica has been working at Nordic for more than 10 years. She's been doing tons of fibrosis research and has been involved in both kidney and cardiovascular research. I hope that the research that Federica is doing together with some of our collaborators is going to really make an impact in heart failure. We have fantastic collaborators there, Lesau and others that really are pushing way forward for segregating patients and understanding HFpEF and heart failure. So I can't wait to hear what Federica is going to show and to show us. So questions to be asked in the question answering section. And Federica?
Yes, thank you, Martin, for the kind introduction. Let me just share my screen. Can you confirm that you can see it?
We see it perfectly.
Great, thank you. So as Morten mentioned, my name is Federica Genovese, and I'm the director of the Cardiovascular and Renal Research Group at Nordic Bioscience. Today, I'm going to talk to you about the role of the extracellular matrix in cardiovascular disease. I'm going to use two disease models, which are atherosclerosis and heart failure with preserved ejection fraction. Let me start by asking you, what do we die from? So I guess that an audience that is largely of people in medicine, you would be not surprised to know that we die mostly from heart disease. Of course, this graph was pre-COVID, so there may be some alteration this year, and just followed by cancer. So, but is this the common perception of how things are going? If we look at Google searches, we can see that heart disease occupies just a very, very minimum part. And people apparently think that we die mostly from cancer and from other causes that actually don't have so much impact, such as terrorism or suicide. And how the media present this? Well, it's kind of the same picture. Heart disease is very, very neglected, and actually causes of death like terrorism and homicide are largely overrepresented. So if our number one killer is so much on the back of our head, then how is the extracellular matrix as cause of this killer is? The extracellular matrix is actually very important, and it is present in the cardiovascular system in different zones. So let me guide you through it. If we look at the heart, let me just take a pointer. Then we see that the cardiomyocytes, which are the main cells in the heart, are surrounded by a basement membrane layer, constituted, of course, mostly by collagen type 4, laminin, and the protoglycans. And then in the middle of cardiomyocytes, there are perimysial and endomysial collagens. This very abundant extracellular matrix helps the heart function as it should. It helps it contract and overstretch, and it helps the conduction of the electrical signals that are fundamental for heart contraction. Of course, another part in which the connective tissue is very prevalent in the heart are the cardiac valves. They are constituted only by connective tissue, and not only by collagens, but also by elastic fibers and protoglycans. This kind of metrics help the valve bear the stress of opening and closing all day, every day, and of course bear the forces of compression and extension they need to go through. Extracellular matrix is also very prominent in the vessels, in which they are present in different layers. The layer just below the endothelial cells is the basement membrane, and then there are other kind of extracellular matrix proteins in the other layers. The ECM in the vessels help them have the kind of resistance that they should have given the high pressure that the blood is exerting on the vessels all day, every day. And so it prevents elastic deformation, and it helps the contraction in the case of small arteries. The first disease I want to talk to you about today is heart failure with preserved ejection fraction, or HFpEF. as opposite as its sister disease, heart failure with reduced ejection fraction. In this case, patients don't have any problem in the amount of blood that is pumped out of the heart. They actually have a normal ejection fraction. However, these patients still experience a disease which is affecting their quality of life a lot, and will ultimately lead them to death. So this is a complex clinical syndrome, which is mostly driven by comorbidities. The risk factors to have a HFpEF are aging, obesity, diabetes, and kidney disease. And a lot of different cells are involved in the pathogenesis of HFpEF in the cardiac tissue. So there is systemic inflammation, so presence of inflammatory cells. The cardiomyocytes become hypertrophic, so they become bigger. There is an altered cell signaling, and the myocardium becomes ischemic. And there is a structural remodeling of the heart, which involves an increased stiffness and then an elevated presence of fibrosis. All these components anyway drive and contribute to fibrogenesis. And that's why we thought that examining markers of ECM remodeling in this disease was particularly relevant. In the heart, there are two main kinds of fibrosis. The first one is called replacement fibrosis, which is subsequent to an acute event, such as infarct or ischemia, in which cardiomyocytes die, and the connective tissue substitute the part of the heart in which the cardiomyocytes have died. The other kind of fibrosis is reactive fibrosis. This is a more chronic consequence to a constant pressure and volume overload to the heart. This causes hypertrophy of the cardiomyocyte. You can see here they become bigger. The cells that produce the matrix are activated, and they produce extracellular matrix, which is dysregulated in quantity and in quality, and causes alteration to the mechanical structure of the heart. If we look at the microscope, this is how tissue looks like. So when we have a replacement fibrosis, there are these large bands of connective tissue and no cells present. And if we look at reactive fibrosis, you can see here these thin bands of collagens in between hypertrophic cardiomyocytes. Different diseases can cause these different kinds of fibrosis. Just an example, if we look at ischemic heart disease, which is an acute event, then the reparative fibrosis or replacement fibrosis, it's a synonym, then it's much more present. In diseases which are more chronic, such as hypertensive heart disease, then the reactive fibrosis is more prevalent. But it's not only the quantity of the extracellular matrix that is important, but it is also the quality. So if we look at this section of endomyocardial tissue from patients with heart failure, you can see here stained in green collagen type 1 and in yellow collagen type 3. And you can see here that collagen type 1 is vastly prevalent over collagen type 3. However, it's not always the case. There are some diseases in which this balance is completely shifted. For example, while in hypertensive heart disease, we can see a prevalence of collagen type 1 over collagen type 3. In ischemic cardiomyopathy, this is the opposite happens. So there is more collagen type 3 than collagen type 1. And what does this mean? This means that these patients have a different cardiac tissue. This is because collagen type 3 gives rise to a more elastic environment, while collagen type 1 gives rise to a more stiff matrix. So of course, especially in the case of an organ that contracts so much, it's really crucial which kind of mechanical aspect the tissue has. And if we look at another kind of quality change in the extracellular matrix, which is the post-translational modifications, and I take a cross-linking here as an example, we can see here that in this graph, we have on the y-axis the left ventricular ejection fraction, so the lower, the worse. And we can see here that there is a negative correlation with the collagen volume fraction. So the more collagen there is, the lower the ejection fraction is. in these patients. However, cross-linking also counts. In fact, the more cross-linking there is in these patients, the lower the left ventricular ejection fraction. So it's not only quantity, but also quality of the collagens that matter. I'm going to talk to you about biomarkers, of course, as every other of my colleagues. And I would like to start with some non-Nordic Bioscience biomarkers. These are commercial biomarker of collagen type 3 and type 1 remodeling. I'm starting with collagen type 3. You have already heard from my colleagues that when collagen type 3 is produced, the propeptides are cleaved off. And there is this marker called the P3MP, which is also used in the liver field, which detects the propeptide, the N-terminal propeptide of collagen type 3. The same is true for collagen type 1. So the biomarker PICP and PINP, they are the markers detecting the propeptides of collagen type 1, therefore collagen type 1 formation. And then there is a marker called the CITP, which is a degradation fragment of collagen type 1 generated by MMP1. So these three markers have been evaluated in many different cohorts during the years, and I'm going to present you a couple of examples here. First example is in Paragon HF, which is a study on HFpEF patients treated with the sacubitril valsartan, which is an ARNI. And they have looked at what was the effect on markers of collagen remodeling. You can see here that the treatment with sacubitril valsartan decreased the levels of collagen type 3 formation and increased the levels of collagen type 1 degradation. So there was a shift in the balance of these two collagens. PIMP was not altered, so the formation of collagen type 1, at least as observed by this marker. However, when we look at Paramount, which was the phase 2 study, the same results were not obtained. So actually, the results are not reproducible very often. If we look at another drug that is largely used in patients with a heart disease, spironolactone, I brought here an example from RALES, which is a study from year 2000, in which patients with high level of P3MP were at higher risk of dying. And then the authors looked at how P3MP changed with treatment with spironolactone. And to do that, they did the exercise of dividing patients in low baseline P3MP and high baseline P3MP. Only the patients that had high baseline P3MP had a significant decrease in P3MP in 6 months with spironolactone treatment. But how does this translate to the outcome? So patients that had a P3MP above the median in the placebo arm actually kept dying, but those that were treated with spironolactone, they had a much lower mortality over 30 months, while patients that had low levels of P3MP, they were actually not benefiting from the treatment. So it seems all good. However, when the results were reproduced in another study, Homage, P3MP was not changing with the treatment. On the contrary, PICP and CITP were altered. So it seems in this case that spironolactone affects collagen type 3 formation, by collagen type 1 formation by decreasing it, and the collagen type 1 degradation by increasing it. So I just brought a couple of examples to let you know what is out there. However, multiple studies are showing that there is much more to it than just PIMP or PICP, CITP, and P3MP. And in this study of urinary proteomics on patients with suspected heart failure, the authors have found out that there are some fragments of collagen type 1 which are associated with an increased risk of heart failure death. These are those in red. And some others that are associated with a decreased risk of heart failure death. And these are those in blue. And when they looked a bit like how or where they localized in the molecule, they found out that the blue ones, so the ones associated with a decreased risk, they were localized in the central part of the molecule, while those associated with an increased risk were localized in the N and C terminal part. Hence, probably this red ones, they were markers of formation of collagen type 1, while these ones were markers of degradation. And this would explain why the difference association with the heart failure death. When the traditional markers were measured in serum, PICP, so formation of collagen type 1, was not associated with an increased risk of death, and the degradation fragment in this case was associated with an increased risk of death. So you can see here that the picture is much more complicated than just measuring a couple of markers. And there is not only more to collagen type 1 itself, but there is also more than collagen type 1 and 3. If we look at this study, these are mice that were subjected, they were undergoing a myocardial infarction. They were terminated at different time points, and then their tissue was taken from the injured part of the heart, so the one that underwent the infarct, and a remote area. And then a transcriptomic study showed that a lot of the collagens were differentially regulated over time in the infarcted area, but not in the remote area. So you can see here there is collagen type 1 and collagen type 3, but there are also many, many other collagens. There are collagens of the basement membrane, like collagen 4, 8, and 18. There are interstitial collagen, collagen 5, collagen 6, and so on. So you can see here that there is an inspiration to what we should look at just looking at this kind of studies. Another example of this is not MI. This is actually a patient that underwent a mitral valve replacement surgery, and while changing their valve, they were taken a biopsy from the left and the right atrium. These patients had dilation in the left atrium. So a proteomic analysis revealed that the proteins that you see in green, they were those that were upregulated in the left atrium, that was the dilated one. And those in blue, they were upregulated in the right atrium. So you can see here that, yes, there is collagen 1 and collagen type 3, but the biggest bubbles, and the bigger, it means that there was a larger prevalence of these collagens. You can see it's actually collagen type 6, the alpha 1, the alpha 2, and the alpha 3 chain, collagen type 12, collagen type 5. So there were different collagens, just 1 and 3. And if we look at the right atrium, then we can see that there were different collagens that were upregulated, and surprisingly, another chain of collagen type 6, the alpha 6 chain, and then collagen type 28. So this is to say that there is more to that than just collagen type 1 and 3. We decided then to apply our protein fingerprint technology, and this is almost one of the last presentations, so I bet that you have heard this a couple of times already. But let me just tell you again that with our technology, we are able to distinguish between the processes of fibrolysis and fibrogenesis. So to be able to see whether in a certain disease, a process of collagen degradation is prevailing or a process of formation is prevailing. But it's not only degradation and formation, it's what is behind them. Because degradation of collagen, what it really is the effect of inflammatory cells on the matrix. Inflammatory cells produce proteases that cleave collagens and other ECM proteins. And then these fragments are released and can be recognized by the neoepitope-specific antibodies. In the case of fibrogenesis, we are looking at another process. We are looking at the activity of the fibroblasts, which are the main collagen-producing cells. And how do we target fibrogenesis is by targeting the propeptides, which are naturally cleaved off during maturation, as I was telling you before. So by producing these antibodies that target specifically the cleaved propeptide, we are able to describe a process of fibrogenesis. Regarding nomenclature, just for you to know what these names mean, if we have a marker that is called C, a number, and then a letter, it means that it's a collagen type 1 in this case, degraded by MMPs. So this kind of nomenclature here is for degradation markers. While the formation markers, we call them Pro-C something. So Pro-C3 is formation of collagen type 3. We started by looking at a cohort of women with angina So they were referred to the hospital, and they had the T1 mapping to detect the presence of myocardial fibrosis. We measured the levels of a lot of different markers of collagen degradation and formation. And we compared the levels in 32 healthy controls. And you can see here that the levels of the collagens changes a lot. And consider that these women are not heart failure patients. They are women with angina. They are fairly young. They are in the 50s and 60s. And they are quite a clean population. They don't have a lot of comorbidities. So this is just a picture of how the collagen remodeling is altered in patients that have only heart disease. You can see here an interesting part. If you look at collagen type 6, for example, then you can see that formation of collagen type 6 measured by process 6 increases in this case, while degradation decreases. And if we look at collagen type 3, we have the opposite picture. Formation of collagen type 3 decreases, while degradation of collagen type 3 increases. So it's not only looking at formation and degradation that matters, but it's even which collagens we are looking at, because we can have a completely different profile of remodeling. One of the molecules that we're mostly interested in, and Daniel just described it to you, is endotrophin. Is this a signaling molecule coming from collagen type 6? So collagen type 6 is constituted of 3 different chains, and the alpha-3 chain at the C-terminal has a domain which is cleaved off during maturation. So the moment that the collagen leaves the cells, this fragment is released. And when this fragment is further degraded by BMP1, it gives rise to endotrophin, which is this bioactive molecule, which has a lot of different deleterious effects. For example, it is pro-inflammatory because it chemoattracts macrophages. It is pro-angiogenic because it recruits endothelial cells. It can stimulate epithelial to mesenchymal transition, so it has a profibrotic effect. In the liver, it can increase steatosis and cause hepatocytes apoptosis. And it's also pro-diabetic because it can increase insulin resistance. We are able to measure the levels of endotrophin in circulation with our marker process 6. So what we did as a first proof of concept, we wanted to know how is collagen type 6 looking in cardiac fibroblasts. So we did our scar-in a jar model with primary cardiac fibroblasts. We treated with the cells with different stimulants, and we saw something interesting, that as opposite as other interstitial collagens, such as type 1 and type 3 collagen, that are stimulated by TGF-beta, process 6 formation is actually not stimulated by TGF-beta. If anything, we see a suppression of the signal. But when we stimulate the cells with the PDGF, then we see an increase in process 6. So it is a different pathway that signals the fibroblast to produce collagen 6. And what happens when we add endotrophins to these cells? Then we can see an induction of the formation of collagen type 3 at the same level as TGF-beta and PDGF. So this is a potent fibroblast stimulant molecule. This led us to elaborate this kind of a hypothesis that collagen type 6, in its structure, it has a lot of von Willebrand factor binding domains. So collagen type 6, lying behind the basement membrane, can actually attract von Willebrand factor, which recruits platelets. Platelets produce PDGF, which we know stimulate collagen type 6. And the moment collagen type 6 is formed, there is the release of endotrophin, which itself can stimulate fibroblast. And therefore, there is a self-perpetuating cycle of fibroblast and fibrosis activation, which is dependent on collagen type 6. As a biomarker, we have examined process 6 in several different cohorts. Daniel has shown you, has shown you some of them. Actually, this was also in a slide deck, I believe. And it is patients with type 2 diabetes. We have observed that the patients that had the highest level of process 6 at baseline had also a higher risk of dying and experiencing cardiovascular events. And when we adjusted for conventional risk factors that are associated with mortality and cardiovascular events, including biomarkers of kidney function, as we know that PROC6 is very associated with kidney function, the association of PROC6 with the outcomes was still very significant. And adding PROC6 to the model was actually increasing the ability of the model to classify the patients in the right outcome. We repeated the same in Canvas, as Daniel also showed you. Let me repeat it here, only looking at the cardiovascular outcomes. High level of PROC6 were indicative of a higher risk of heart failure, cardiovascular death, a composite of the two, or all-cause mortality. And also in this case, as adjusting for the traditional risk factors kept the significance of the association of PROC6 levels with the outcomes. To go to heart failure with preserved ejection fraction, we have now measured PROC6 in and confirmed the results in 10 separate cohorts. So let me show you the first one, TopCat. We have measured a subset of TopCat, the American cohort, which was available for biomarker studies. And we have seen that the PROC6 measured at baseline was also in this case indicative of a higher risk of experiencing the primary endpoint. In this case, the primary endpoint was cardiovascular death, aborted cardiac arrest, and hospitalization for heart failure. Also in this case, data were adjusted for all these different parameters, including kidney parameters. So when we looked at how PROC6 performs compared to NT-proBNP, which is a commonly used biomarker in heart failure, and with the MAGIC score, we could see that for both the primary endpoint and either death or heart failure hospitalization, PROC6 was clearly outperforming both NT-proBNP and the MAGIC score. As I told you, we have repeated this data in many different cohorts. Let me show you here another one, a smaller cohort of patients with heart failure. Also in this case, PROC6 was very associated with mortality risk. In this cohort, we decided to do a little exercise. So we actually measured several markers of collagen formation and collagen degradation. So we asked ourselves the question, so let's have a look at how different models perform. So we did a confounders model, including all the parameters, the clinical parameters that are usually associated with increased risk of event. Then we did the formation model with collagen type 3, 6, 8, and 28 formation, and the degradation model with collagen type 1, 3, and 4 degradation. As you can see here, the best model was the formation model. It was extremely associated with outcome, with an area under the curve of 0.94. The degradation model was actually not informative for outcome in this case, and the confounder model was, but to a lower extent than the formation model. Let me just conclude this part by telling you that this confirmation in 10 independent cohorts is currently undergoing paper writing, and we hope to submit this paper to a high-tier journal very soon. And I would like to thank especially our collaborators, Lei and Julio, that are driving this. So let's look a little bit at myocardial infarction. Because we have talked about chronic processes, now I would like to see if biomarker of ECM can actually be relevant in acute processes, such as MI. So if we look at how MI consequence pan out, then after the acute event, there is immediately cardiomyocyte death, infiltration of inflammatory cells, and extracellular matrix becomes degraded. Then there is, after a couple of days after the infarct, a process of wound healing. And after 3 days and on, then there is increased collagen deposition, which forms the scar in the left ventricle and the left ventricular remodeling. So we have examined biomarkers of collagen type 1 and type 4 degradation. And you can see here that actually the picture that we see with our biomarkers is exactly this one. In the early time points after MI, we see an elevation of both collagen type 1 and collagen type 4 degradation, and then a decrease in later time points to initial levels. On the contrary, when we look at collagen type 6 formation in this case, Then we see an initial increase as early as 3 days after the infarct, which keeps being increased over time. This is the process that causes the scar, that causes accumulation of collagen, and in some of the patients leads to heart failure. To conclude my talk, I would like to talk to you about the second disease that I anticipated, which is atherosclerosis. And the reason why I want to do that is because I want to show you that fibrosis is not necessarily a bad thing in the cardiovascular system. If we look at the formation of an atherosclerotic plaque, then we see that we want to have a stable plaque. We want to have a plaque in which the fibrous cap is maintained, the plaque heals, and to heal, inflammatory cells stimulating fibroblasts facilitate the production of collagens, which protect the fibrous cap. On the contrary, when there is a process of inflammation with a consequent production of MMPs, then collagen is degraded. This fibrous cap is actually ruined, and the plaque can rupture and can cause thrombosis. So we asked ourselves, when we look at atherosclerosis patients, shouldn't then biomarker of collagen degradation be relevant? And they were. We look here in this cohort of patients with atherosclerosis in their carotid artery, that when measuring collagen type 1 degradation, C1m, in serum, patients with high levels of this biomarker were those at higher risk of experiencing cardiovascular events, cardiovascular mortality, and all-cause mortality. And the association was maintained even after adjustment for parameters that are normally associated in atherosclerotic patients with events. But we looked also at basement membrane. So we looked at collagen type 4 degradation and laminin degradation. These are the two extracellular matrix proteins most abundant in the basement membrane. And also in this case, having high level of degradation of the basement membrane biomarkers was associated with a higher risk of mortality. And also in this case, adjusting for conventional risk factors did not modify the association, significant association with outcome for both markers. What about process 6? Of course, we looked at endotrophin also in atherosclerosis, and we could also stain, in this case, the atherosclerotic plaque. We saw that there is a lot of process 6 deposited in the atherosclerotic plaque. And when we asked ourselves the question, how does it look in the patient? We saw that high level were associated to a phenotype of patients, which is associated with a worse outcome. So it was higher in hypertensive patients, in obese patients, and in patients with diabetes. When we looked at outcome, we saw that process 6 was associated to all 3 outcomes, even when adjusted for conventional risk factors. So I hope in my short talk, I have conveyed some important messages to you. First one is that fibrosis is an important feature of cardiovascular disease. It's not necessarily a bad thing. It depends which cardiovascular disease you're looking at. That collagen type 1 and type 3 are just the tip of the iceberg. There is much more to it than just these 2 collagens, despite them being the conventional ones and those that are considered to be the most abundant. We need to look at other collagens. We need to look at other post-translational modifications. We need to look at cross-linking. And there is a lot still to be discovered. We hope in the next years to be able to contribute to the research with a lot of different collagen biomarkers. And then it's very important to check the balance between formation and degradation, because just measuring, just saying this collagen there is more of this collagen in tissue, there is less of this collagen in the tissue, is not really informative of the dynamics of the remodeling. And last, we really need to look at the extracellular matrix as a signaling molecule source, because the matrix can be very dangerous. So with this, I would like to thank my team at Nordic Bioscience. I would like to thank especially Sine, Alexander, and Daniel, who provided the results that I presented here in this slide deck. And then our collaborators, without whom I would not have all these nice cohorts, and of course, all the patients that participated to the studies. Thank you very much.